Well, good morning, good afternoon, good evening, and welcome to this webinar today. This webinar is co-sponsored by ICAP at Columbia University and the Herbert Irving Comprehensive Cancer Center at Columbia University as well. And today it gives us a great pleasure to welcome Dr. Ophira Ginsberg, who's going to be giving today's grand rounds on women, power, and the cancer divide. I'm Wafa El-Sadr, I'm the ICAP Global Director, and it gives me great pleasure now to ask Dr. Judith Jacobson to present Dr. Ginsberg. And Dr. Jacobson is an associate professor at Columbia University and a member of the Herbert Irving Comprehensive Cancer Center here at the university. Judy?
Thank you, Wafa. So I'm very happy to introduce Dr. Ophira Ginsberg, whom I've known for about 5 years. She's Canadian-born. She's a medical oncologist and global women's health researcher with nearly 20 years experience in global cancer prevention and control. She recently received the 2022 American Society of Clinical Oncology Humanitarian Award. And on March 8th of this year, which is not only International Women's Day, but my own mother's birthday, the U.S. National Cancer Institute announced that she is now Senior Scientific Officer and Senior Advisor for Clinical Research at the NCI Center for Global Health. She's co-chair of the recently formed Lancet Commission on Women and Cancer. So Ophira, welcome. I'm looking forward to learning all about the Commission's work.
Thanks so much, Judy, and thanks so much, Wafa, and everyone for attending today. It's really an honor to give these rounds. Just going to start by sharing my screen and with a moment here as just to say I have no financial relationships to disclose. And I used to say that the only disclaimer I had was that I was in fact Canadian, but you beat me to that. So it does sort of shape the way I think, having grown up in a very privileged position, which I recognize. And I do want to say something about diversity, equity, and inclusion at the start, that some people do question even the language of having a commission on women and cancer, and are we being inclusive? I hope by the end of this session, you'll understand sort of what our approach is, and you're most welcome to, of course, critique and ask questions as you wish here and afterwards. I will say that when I say the word women throughout this talk, I mean all women, women cis or trans, and also we are addressing or hope to address the needs of people of all genders, in fact. So it's a little bit sneaky actually to use the word women when we're really meaning something beyond that. And starting with one of my favorite people and his great book, Factfulness, Dr. Hans Rosling, said that factfulness is recognizing that a single perspective can limit our imagination. And so it's better to look at problems from many angles to get a more accurate understanding and find practical solutions. Sounds pretty obvious, but we really, really need to stop sometimes and think about what we're doing, particularly if we're very involved in a highly narrow focal area of our research, for example, to step back and look at the big picture. And as Dr. Roslings would say, to control the single perspective instinct, get a toolbox, not a hammer. And so that's sort of our approach to this topic. The first sort of data I want to show you is from Dr. Freddie Bray, who's the Cancer Surveillance Unit, the head of the branch on cancer surveillance at IARC. That's the WHO's specialized agency for cancer. I'm going to refer to it a number of times as IARC. That's the International Agency for Research on Cancer, where I spent some time last year as a senior visiting scientist. And last year, he and Dr. Isabel Sorio-Mataram, who's senior author on this important, although brief communication, she is one of our co-chairs on the commission. They tried to draw attention to the importance of cancer as a leading cause of premature death worldwide. And the reason why I'm going to open with this, with one map, I'm not going to show that many maps this time, but just for the fact that I think this is a fairly diverse audience from different intellectual, perspectives. Of course, some folks, because this is an ICAP grand rounds, I'm sure have deep expertise on the issues regarding HIV and AIDS. And of course, some of you may be aware of HIV-related malignancies, AIDS-related malignancies. However, to put this into context of the spectrum of non-communicable diseases and other major health issues that all people in all countries are faced with. Here's one map just to show you. The light blue is where cardiovascular disease is the #1 cause of premature deaths. That's according to the UN Sustainable Development Goals, death of an individual between the age of 30 and 69, so under the age of 70. And you can see here in the light blue where cardiovascular is first and cancer is second, and that's about 70 countries. Then where cancer is first and has overtaken cardiovascular disease as the primary cause of premature death, we have 57 countries, including, as you can see, North America, Europe, a lot of high-income countries, including China, well, not only high-income countries, but also Australia, etc. Now let's take a look here at the African continent. And I am careful about the phrase sub-Saharan Africa. I understand that that is also falling out of favor for probably very good reasons. When we look at the African continent, we can see that cardiovascular disease and cancer rank in the top 3 causes of premature mortality in 50 countries. And so we're really only looking at a handful of countries, 6 countries in total, where cardiovascular disease or cancer are not in the top 3. Now, when it comes to cancer statistics, and this is all from IARC, part of the WHO, these are just the estimates of the projected increase in new cases of cancer to 2040. The projections were made in 2020, and we're looking ahead to 2040, and this is for both sexes of all ages. About 19.3 million individuals were diagnosed in 2020, and we're seeing that increase vastly to almost 30 million individuals. Some of this is not women and men. The blue is meant to reflect demographic changes. That's just due to demographics. And the other causes, well, we'll get into that a bit when we talk about cancer in women. Here we see for both sexes the mortality. Almost 10 million individuals died of cancer in 2020, and we're seeing that increase to 16.2 million over, now it's looming ahead now, we're into 2022. This is by 2040. Now let's focus our attention on women. We can see about 9 million women being diagnosed, or rather being diagnosed in 2020 to 13 million in 2040. A lot, but less than half is due to demographic changes. And here are the numbers of women who died in 2020 and will be expected to die of cancer if nothing changes, except of course demographics and if the status quo is maintained. And when we focus in on the 2 cancers that we emphasized as sort of marker cancers when we talk about gender inequality, social inequality, and cancer, and this was the basis of the series we put together in the Lancet a few years back that I'm going to talk more about. Every minute, a woman dies from breast cancer. And every 2 minutes, a woman dies from cervical cancer. Now, for those of you who know a lot about cervical cancer, you'd be aware of this, but some of you may not. All told, just from those 2 cancers, that's more than 1 million women in 2020. And most of the women who died prematurely from both those cancers. And these were largely preventable deaths. Now, you may wonder, what am I talking about? Cervical cancer we know is preventable, right? With vaccination and screening and effective access, equitable access to high quality treatment for precancers and women or other people with cervixes, which should be assumed for the rest of the talk. For individuals who are at risk of cervical cancer, this is preventable. In the case of breast cancer, the cancers themselves are to some degree preventable, and we're not going to get into the epidemiology of breast cancer too much, but to say that the deaths are largely preventable because we know how to detect breast cancer early, and with appropriate access to effective care, many of those deaths can be averted. When it comes to cervical cancer, we're talking about the epitome of cancer health disparities or global health inequities, or whatever language you prefer to use. 9 in 10 women who die of cervical cancer were living in a low-income or middle-income country. And in a high-income country like my native country, Canada, or my adopted country, the United States, most individuals who develop and die of cervical cancer, who develop invasive disease and who die of cervical cancer, are likely to be among the most marginalized women or people who have cervixes in our societies, including trans individuals, including people who are from indigenous communities, including those who are geographically remote. women who are very obese also seem to have lower screening rates. And finally, to show you something that's already come from the commission since the commission was launched, this is a project, it was a short report in the Lancet Oncology by Dr. Salvatore Vaccarella from IARC, myself and Dr. Freddie Bray. And we just took a look at all of the adults between, adulthood, age 20 to age 50. So adults under the age of 50. And we looked at least the sex breakdown. Sex, as we have in cancer registries, is mostly still by biological sex, is that in 2020, 2/3 of the 3 million adults diagnosed with cancer under the age of 50 were women. And we hadn't known that until we looked at it. It's like these data points are hiding in plain sight to some degree. This is the only slide I'm going to show that has unpublished material from the commission, so I'd ask you not to reproduce it, is to say, we're going to show something like this, where we look at cumulative risk of incidence and mortality, okay, incidence being blue and mortality being red. We've got men on the left-hand side and females on the right-hand, males and females like this. And we've got different countries, and we can see the lower end of the income level, lower human development index also is on the bottom, and you have the more wealthy, et cetera, countries on the top. There's a vast difference, right, in terms of the incidence of cancer, and that's for many reasons. That's growing most often, most rapidly in low and middle income countries. But as a snapshot in 2020, yes, you can see there's a big difference here in incidence from these countries to these countries, and between males and females, not that different. But look what happens when we track mortality, when we track the cumulative risk of dying. We can see that there's not a big difference here, right? So in fact, if you're born in Western Africa, for example, and you're female, you're almost as likely to die of cancer as somebody born in Australia. There's not major differences there. And so we need to unpack that. And moreover, this is really a matter of equity. This is the only sort of graphic slide I'm going to show, but I think it's important to highlight what we're talking about here, especially for those of you who might be physicians, clinicians, nurses, et cetera, people coming across folks with cancer, or of course here in the US, if you're based at Columbia University in the Cancer Center. You'll know that this is a mammogram. Some may not recognize it as a digital mammogram. This is from the Ontario Breast Screening Program. I used to work closely with them when I was there, and we can see there's an arrow pointing to a tiny dot because it's hard to see. That's a very small, less than 1 centimeter, probably hormone receptor positive, a particular type of common type of breast cancer, at least in many, not all populations. And that's going to be a stage 1 cancer. Okay, so that's somebody who the cancer hasn't spread to the lymph nodes. She has an excellent prognosis, probably with surgery, maybe radiation, perhaps a pill once a day. And depending on the characteristics of the tumor, she might need other treatment as well. But she's got a very high chance, 90%, let's say, of survival in many settings. And here on the right is a photograph I took in my first day in a clinic I co-founded in rural Bangladesh many years ago, more than a decade ago. And I frame this in terms of an equity imperative, a phrase that was coined by Felicia Nall, who's also co-leading another commission that'll be coming out sometime after ours on health systems and cancer in the Lancet. We can see here that she has this unfortunate woman who was 43 years old, came to us with a fungating mass poking through the skin already for some time, and the whole breast is replaced with tumor. She could hardly move her arm. And the chances are that, I think in her case, she came in having had a friend bring her because her family could no longer stand the smell. The question we're often asked, why didn't she present sooner? Now, the word present is a problem, right? The word present assumes that this woman had every possible opportunity to come for care. She had somewhere to come. She could afford treatment. She was aware that this was potentially treatable, even potentially curable if she came early enough, et cetera, et cetera. Many assumptions that we make of the women and men, for that matter, who we treat. And so the language is changing. We're trying to change this to, diagnostic, why wasn't she diagnosed earlier? Presentation may have not been the problem. She may have gone for care, but she received incorrect information and was sent home with a salve or something for her breast. And then a year later, she comes to the clinic like this, or she simply was ashamed or she was facing stigma about a cancer diagnosis. And this all leads me to Dr. Verona Vanderpoy, who's our other co-chair of the Lancet Commission on Women and Cancer, a very well-known and beloved radiation oncologist in Accra, Ghana. And she says, whenever she brings that kind of thing up with her patients, they remind her, you have to understand me to help me. Now, this will sound familiar to those of you working closely with individuals, with patients with different conditions, in particular, I'm sure with HIV/AIDS as well in many, many settings. So we have to ask the right questions, and we have to be present for people to be able to really listen, And so this is more than 10 years ago. We published a rather complex paper that covered a lot of territory, including some qualitative data. And we asked women, the first few hundred who came to our clinic, why didn't they seek care earlier? And most of them said, did you know you had a problem? When did you know you had a problem? And basically, as an old mentor of mine used to say, these women were poor. They weren't stupid. They were making very wise decisions for themselves that made sense to them, right? Many of them told us they had no choice. And that was the title of a short documentary film I'm trying to track down now. It used to be available on YouTube. That was put together by one of our Bangladeshi colleagues who used to work for BBC. The concept of choice is really important here. And here are some quotes of women we interviewed. It is evil. Once it visits your house, it kills. No one getting cancer gets saved. It's a curse from God. This is not unique to Bangladesh. It's not unique to any one culture or society. Myths about cancer have existed since cancer has existed, and frankly, were present and still are to some degree in Canada or elsewhere. We didn't used to talk about cancer at the dinner table, especially breast cancer. It's become destigmatized to a large degree, but not completely. Cervical cancer is incredibly stigmatizing in many cultures still, many countries. And then you have the issue about abandonment. When I told my husband I had breast cancer, he said, I don't want anything to do with you. You can go die. And have I seen people who were divorced because of their breast cancer diagnosis, whose partners left them for many reasons, different reasons they might have given? Have I seen that here? Of course I have. It's not just in Bangladesh. So switching gears to something a little more uplifting, because it's something we can do something about. We can do a lot about stigma as well. It's a big challenge. I'm giving you some of the doom and gloom, but I want to switch gears now on the prevention side and why women are facing more cancer over time and how we can address that with good research questions. Well, there's the epidemiological transition, which I've already talked about. There's exposures increasing to tobacco, and not just tobacco that's smoked, but smokeless tobacco. You might not know that in India, oral cancer caused by smokeless tobacco is one of the #1 causes of cancer-related death among women, not just men. And that's not from smoking, but it's from taking in these other products that are commonly found. Alcohol is an increasing issue. I'm going to get into that in a moment. Poor diet, sedentary lifestyle. Now think for a minute. I'm just going to step out and think about the various ways in which women and young girls, let's say, are exposed to factors that can cause cancer that may not be obvious to us. So imagine if you are somebody who's living in a small village in rural, I want to say Southern Africa, let's say, and you need to go get firewood. And the fear about getting firewood or going for water, of course, is a risk of perhaps sexual violence. That violence can put you at risk of HIV. It can also put you at risk of cervical cancer. I mean, that's a really kind of convoluted way of looking at it, but it gives us a sense of what people, not just girls, women, or people of any gender, might face that can compound their marginalization, that can increase their risks of developing a chronic disease. Hormonal exposures are for sure a major factor in breast cancer. And if you don't happen to know, breast cancer rates are increasing much more rapidly in low and middle income countries than they are in high income countries. And that's adjusted for the age, as age standardized incidence rates, largely because of changes in reproductive patterns. They're having their periods earlier, just like we saw over 100 years in the US. Girls might have had their first menstrual cycle at 16, and now it's 12, in many cases younger. And we also see people, if they are able to and have the choice, I'm not going to get into that, to plan their pregnancies when they want them and space them the way they want them? Well, most people, if they can choose, are going to stay in school longer, which is great. They're going to delay. They're not going to have child marriage, which is excellent, to avoid such a calamity. But these happen to be risk factors for breast cancer. So later childbearing, fewer children, and in some or many cases, less opportunity for long-term breastfeeding. And breastfeeding is a lovely way to improve the odds for children and also reduce the risk of breast cancer. So when we talk about all these modifiable risk factors, to what degree are these really modifiable? So here's just a few little snapshots of advertisements that aren't that long ago, probably longer ago than many of you were born. I can't see people's faces, but I'm going to assume one of the older people here. But anyway, you might be able to glean that this is sometime in the 80s, given the shoulder pads. And we can see here that this is an ad for tobacco, Virginia Slims. The word Slims was there for a reason. They're showing it, trying to connect the dots between women's empowerment and smoking, right? And this was not just to white women in the US. We're talking about also a way to keep slim by smoking and to play at women's vulnerabilities, which are already a cultural phenomenon that is in many ways meant to keep women from full equality. And we can see here, I took this from the WHO's website. I'm not sure if this was a real ad or if it was a mock-up, but just to highlight the importance that this type of marketing is going far beyond high-income countries and has been for some time. And the same is happening with alcohol, right? This is a BBC report that accompanied an excellent paper I'm going to highlight in a moment, that talked about companies using images of empowerment and busy professionals to target women. And we do see alcohol rates increasing in a very alarming way in many, many countries. This was from Dr. Harriet Rumgay, who I think might actually be on this call now. Brilliant PhD candidate at IARC, who's I think about to defend her thesis. And she already had this terrific paper, The Lancet Oncology, last year that looked at what we call the population attributable fraction of cancers related to alcohol. And here, just a snapshot from France, it was a lot of European data. You can see that even among both sexes, breast cancer is more than 1 in 5 of those cancers. So breast cancer is 22% of all the cancers attributable to alcohol in France. And in the UK, I think it was even more, it was 25%. Here on the left panel was just to draw your attention to the fact that it's not even heavy drinking. For women, a lot of this is due to moderate drinking or a couple of 1 to 2 drinks a day sort of thing. Although for men, it is true that there are many, many more cases. 570,000 cases of cancer were caused by alcohol among men. It's a lot less for women. But our intention in the commission isn't just to say women have it worse than men. In fact, men are more likely to die of cancer. And we absolutely want to acknowledge that. But when we're looking at women, we're looking at how society views women, how power is at the center of women, whether women have the access and opportunity to reduce their risks. And so these are about policy interventions. It's not just about telling women don't drink, don't smoke. We know how ineffective those strategies are by themselves without policy interventions. So here we go to health equity in women's cancer, which was a 3-part series that I had the privilege of leading with about 40 authors from 18 countries. It came out more or less while I was in at WHO. I was there as a medical officer, 2015, 2016. And we also had a few commentaries, which were really, I think the commentaries are well worth reading. They're certainly not dated. The papers undertook a review. For those of you who don't know what a Lancet Commission is, a series is different than a commission. A series is more about synthesis, review of existing information to raise questions that could then be taken up by others, including in a commission, which is an original piece of research. We did make some recommendations, and one of the commentaries which got a lot of attention and is the title of this talk, I attribute to the great Dr. Michelle Bachelet, who at the time was the president of Chile. We really wanted a female head of state to comment on the series rather. And later, as you know, she became the UN High Commissioner for Human Rights and is the founder of UN Women. And we stated that where a woman lives, her socioeconomic, ethnocultural, or migration status shouldn't mean the difference between life and death from, in this case, we used breast and cervical cancer as marker cancers for which cost-effective, life-saving interventions exist. We talked about cultural and social attitudes, the importance of embedding a gender perspective, et cetera, et cetera. And a couple of calls to action, which included the first set of proposed recommendations for what's now cervical cancer elimination strategy. The numbers, of course, have changed, but we had to start somewhere. And that's about how many girls should be immunized, how many people should be screened, et cetera. And we also made a statement that all women should have equitable access and opportunity for early diagnosis and effective treatment for breast cancer. And so where were we 5 years later? Where we were 5 years later is that I had a conversation with the editor of the Lancet, Richard Horton, at the Lancet lecture. I happened to be in town for London Global Cancer Week, as it's called now. This is a few years ago. And we talked about where we've gone since the series, and if we wanted to maybe consider putting together a commission. So since the series, there's now the elimination strategy for cervical cancer that many of you will be familiar with, 90-70-90, 90% coverage of HPV vaccination. Not to say that boys shouldn't be vaccinated, of course they should, but this was the WHO strategy to get things going, and out of concern, as I understand it, that if you make it boys and girls at the outset, girls may be less likely to get vaccinated than boys. And so we wanted to accelerate things. 70% of screening by a high performance test, and 90% treatment of precancerous lesions and of invasive cancer cases, et cetera. And there's also a newer initiative that you might not know about, the Global Breast Cancer Initiative. I'm involved in on behalf of NCI. It's a WHO global initiative, obviously, to try to develop technical guidance and to really move the needle forward to improve access to care for women with breast cancer, and also to educate women about the risk factors and ways they can get early detection, even in lower resource settings. I'm not going to get into that in this talk, though. Another interesting piece of work that came from the series was by Ray Mayotte, who's now a radiation oncologist in Florida. And he was at the time a fellow in radiation oncology at NYU while I was working at WHO, but I came to give a talk. And he approached me after and said, hey, I read your series, and I worked on, he did an MPH at Harvard and was working with Sylvia Fermenti, who many of you know here in New York, trying to get a way of estimating child mortality associated with maternal mortality, using breast and cervical cancer as sort of a proof of concept, if you put it this way. And so this came from work by others, actually in Bangladesh, that I think Cheryl Ronsman was the first author in a paper more than 10 years ago that showed that if a mother died before the child was 10, if the mother died of any cause before the child reached the age of 10, the child had a much higher chance of, well, a lot of things, but including death, a higher chance of dying before they reached adulthood. And that was even when you looked after age 2, after, exclusive breastfeeding might have been the main issue there, and regardless of cause. So that prompted us to talk about cancer's orphans. I wrote about this in 2013 in the Journal of Cancer Policy. And we're trying now to get our heads around it. Dr. Valerie McCormack, who's another senior scientist at IARC, has a brilliant study called ABCDO, which is about African breast cancer in Africa. It's a prospective cohort study. And after 1 year of following women diagnosed with breast cancer in 5 countries in Africa, they looked at how many unfortunately had died, because most women were diagnosed with advanced disease. There's a lot of really good papers coming out of this group. This one actually counted how many children became maternally orphaned. And they found that for every woman who died, every 100 women who died younger than age 50 in this cohort, they left behind 210 new orphans. So a bunch of people led by Valerie and others at WHO, and I'm involved in this work, are trying now to get a sense of the global impact of maternally or otherwise orphaned children due to cancer. We just haven't had the same kind of attention as some other health conditions to be able to really convince governments as well that cancer cancer care isn't all about expensive radiotherapy, et cetera, which by the way is very cost effective once you acknowledge and adjust for the capital costs. There's a separate commission that made that point beautifully by Dr. Mary Gospodarovich a few years ago. But I would say that the commission that really inspired me to go ahead and try to put together a set of people, first of all, that's the real challenge, to get the right people at the table who are diverse enough in terms of their viewpoints, their science, where they're coming from in terms of the biomedical model or social science models, et cetera, and come together, was this commission, the Commission on Women and Health, Key for Sustainable Development, led by Professor Anna Langer, who I'm now very happy to say is an advisor on our commission. And the main thing to draw attention to here is that they looked at women and health. I always emphasize the and. They looked at a novel way of viewing the relationship between women and health that moved beyond a narrow focus of women as recipients of healthcare, right? And just recipients of care and not necessarily viewed as individuals who have agency, who are at risk of, et cetera, risk factors for health conditions. And they also address the roles of women as providers of healthcare. And this extended to the informal health workforce, which is incredibly important, undervalued, mostly female workforce globally. And so I took from that, I had some conversations with Richard Horton and with Dr. Langer and with others. I also noted ESMO is the European Society of Medical Oncology, starting to look more at gender medicine and cancer in terms of how cancer relates to, or how women as patients for one thing, but also women as oncologists and nurses, et cetera. So this is just a quick thing to show you from this major report that ESMO put out recently of more of the biomedical approach, which we are not taking in our commission. What we will certainly summarize some of this existing literature on host factors, cancer biology, and the effects of drugs. There's a recent paper that's very, very important that looked at, I think over 100,000 women from multiple clinical trial cooperative group data. That's a mouthful for those of you not in the cancer world, but anyway, cancer drugs and their impact on a patient in terms of the effects and toxicity, right? And there are real gender differences. So every time we think about precision medicine and personalized medicine and precision oncology, we should really remember to include biological sex and also gender, by the way, as factors that can be very important. Not just looking at the tumor genetics. It's funny, sometimes we forget to take account. There's a lot more on this. There's a lot more happening. Of course, the NIH has mandated for a long time now that in grant applications, you have to be explicit about the gender or biological sex, at least, even when it comes to cell lines, not just patients, let's say in a clinical trial, and making sure that's reported. And here's a very recent paper by some of our colleagues in the Journal of Clinical Oncology, the specialty journal of global oncology, that talked about authorship equity and gender. And so that's another issue that we are going to try to tackle. It sounds like a lot, but we're already making our final report now, some 2 years after the main launch commentary. And in the last 10 minutes or so, and then I'd like to open it up so we have a good 15 minutes for questions, is to show you a bit about our commission. You can see the website at the bottom. First of all, what is a Lancet Commission? It's basically a 2 to 5 year, usually closer to 5 years, I think, a research project with a multidisciplinary and diverse group of stakeholders. And in our case, very multidisciplinary and very diverse, as I'll show you in a moment. The main product tends to be 25 to 30,000 word report, which is, for those of you not in academic publishing, that's massive. It's like a number of individual research articles. We have up to 20 figures and tables allowed, so it's a lot of visuals as well. And the main thing, of course, is to ensure anybody doing this kind of work has a really good executive summary and really good infographics to accompany the main report because many people will just read that maybe and look at the figures and tables. That's being realistic, but it's what you do with the information that matters. If we were just going to make a report and have it sit on a shelf, honestly, I wouldn't have the enthusiasm I have. What we're hoping to do is, of course, and we have additional manuscripts because there's so much data that we're generating. And we can have blogs and podcasts and talks like this one, but really the key is the real world actions, right? At the moment, we were able to raise some funding actually from our colleagues at another hospital in New York at Mount Sinai, or an organization called The Women, and Dr. Anne-Marie Bedeau, who's GYN oncologist, who's part of our commission, was able to get some funding for us to hire a postdoctoral fellow from Iran. So this is a early-ish career cancer biostatistician from Tehran, who now is at IARC. And this is going to be, we hope, really great for her career development and great for us, of course, to learn about her work. And we'd like to see more opportunities for young women and women of all levels, people from marginalized populations, including gender minorities, to have more opportunities that might come from this kind of commission. So we've got a team of mentees also that are part of the commission, but beyond the report, we'd like to see more happen with our partner organizations. And for me personally, the most interesting of these opportunities are the policy initiatives at national level and through the multilateral organizations of the UN like WHO. So this has happened in the past. Lancet commissions have led to actionable recommendations, for example, with pain and palliative care, with global surgery, and to the point where they can become part of, or even in some cases, a standalone World Health Assembly resolution. And we can talk about that. What does that mean? So to advance an evidence-based and gendered approach to cancer risk and cancer control, our commission is addressing urgent questions at the intersection of social inequality, cancer risk and outcomes, and the status of women in society. And that was the commentary that Richard Horton and I published 2 years ago this month. Our vision is lofty, as all visions are, a world in which every person, regardless of gender, this is the short version, we include gender identity, geography, etc., have the right to accessible, affordable, and quality prevention and care. And this is possible. There's a great deal, I've told you a lot of doom and gloom. We've made tremendous gains in cancer prevention in some cases, and certainly in cancer survival in many cases, in places where there are adequate resources, right? So we can talk about this in the Q&A, but childhood cancer is a great one to mention here, even though it's not about women in cancer. 90% of children will survive childhood cancer. In low and middle income countries, we think we're missing a huge proportion of children that aren't even diagnosed, and they die thinking perhaps the child had malaria, but they were having fevers because of leukemia, right? And they're never diagnosed. And so we see this huge disparity that if everyone has equal opportunity to what we already know works, we would really do a lot to close that divide. The same can be said for breast cancer, right? The same can be said for cervical cancer. And we are taking the lens of intersectional feminism to the commission, which may surprise some of you. It certainly surprised some of our team, but we're all on board now. And this is really just to say, it's about equality, right? This is Kimberly Crenshaw's phrase, intersectional approach shows the way that people's social identities can overlap, creating compounding experiences of discrimination. And that way, we need to look at these as not just the sum of their parts. And so we need to have better data. We need to collect the information that can help us address those aspects of intersectionality. So we are investigating the preventable burden of cancer in women. And in fact, we already have, and we've got a lot of data we're going to show soon enough in the next few months, we'll be submitting for publication. And perhaps some of this will be released a bit before that. We're applying an inclusive economics analysis. So looking at the preventable burden, avertible deaths, premature mortality, and also not neglecting the importance of women who are older, right? This is always a problem when we talk about women's health. We're looking at women of reproductive age. Women are more than their reproductive organs, right? And we will be taking special care to emphasize the vast numbers of women, because cancers mostly affect people who are older, and the ways in which women in particular, even in many high income countries, have been undertreated for cancer at the same stage of disease even. We're going to take stock of the missing leaders in oncology as women. There are many women now leading some of the largest cancer agencies, but that hasn't always been the case, and that doesn't necessarily mean much for the women early in their career, later in their career, and the hidden role of women as caregivers. We have data we're going to show that captures what we think is a first estimate of women as carers in the informal healthcare workforce, at least in a few representative countries, and ultimately to broaden the set of key recommendations. We are very diverse, 3 co-chairs, 16 women, 4 men, 14 countries. More than half are from low and middle income countries, and the half or so that are from high income countries, most actually were born and raised in a low or middle income country. So this is different than a lot of the other cancer commissions. We really wanted to be, kind of walk the walk. We have broad expertise, cancer epidemiology and clinical research, but also gender studies, sociology, economics, and anthropology. We have a long list of advisors. I don't need to show you this now. We have guiding principles that you can see on the website that explain what we mean about intersectional feminism, including the process of the commission. So we build consensus, it's not top down. And there's a lot of language, and there's going to be a lot of work, including a framework that is novel, that looks shifting the culture of cancer away from individual blame, recognizing the role of structural, social, and commercial determinants of health, et cetera, and addressing asymmetries of power, et cetera, et cetera. Now, many of you here listening may say, yeah, we've already done that. We've done that in our domain of healthcare, for example. We're catching up. In the cancer community, there's a lot of catch up we need to do. Even the concept of decolonization is just now beginning to be discussed. So we're trying to be humble about that and make sure we're not just also copying what other people are doing, but really to see if we can disrupt things with, cancer happens to be our area, but there's hopefully more that we can learn and more that we might be able to show that's useful for others. And I'll end with one of my favorite quotes from Professor Davis. I'm no longer accepting the things I cannot change. I'm changing the things I cannot accept. And these are thanks to all our commissioners, advisors, our partners, and we have collaborators and mentees as well. I thank you very much for your attention.
Well, thank you very much, Dr. Ginsberg, for really a very thoughtful and comprehensive presentation, and really applaud you for all the hard work in terms of moving this agenda forward. It's the commitment is very palpable, so thank you. I invite all our attendees, please submit your questions in the chat box, and I'll try to take as many of them as possible during our webinar. But maybe to start the conversation, there's always been this tension, particularly in low-income countries, the tension between focus on prevention versus focus on treatment for cancer, because of the paucity of resources to treat people who are already diagnosed, the few who are already diagnosed, and the cost of investments in treatments and so on. It often kind of ends up being pitting prevention and treatment. What are your thoughts on that?
Yeah, that's a great question. Thanks so much for that. We get asked this a lot. I get asked this a lot, and it's actually really challenging to answer. I think these questions were asked many years ago, decades ago, when in the domain of HIV and AIDS also, is that if you only had $1, would you put it to prevention or treatment? And the slightly cheeky answer is yes. So in fact, these have to be concurrent actions. And I think one of the ways that we can get our heads around how best to approach it is by looking at those opportunities to frame things as an investment case. We can talk humanitarian and rights all day long, but unless we have things that are actionable in terms of convincing ministries of finance to invest or for others to use those opportunities, we're not going to get very far. That said, most of the prevention actions that relate to cancer, at least a few of them, are in common with prevention for the other non-communicable diseases. So you could go a long way to help prevent many thousands of cases of cancer if countries were able to adopt the entire package of interventions for the international framework of tobacco control, for example, and the alcohol-related policies. At the same time, you can be doing things like the vaccination, which we have cost effectiveness data, and the so-called best buys that WHO are just about to update again, actually, looking at those aspects of prevention and care that are considered very cost effective. And then also making those investment cases, as I said. I hope that's one way to look at it. There's a longer answer that I'll save for now.
Yeah, thank you. Another question that we've received is regarding whether the Commission or maybe you can share with us some of the Commission's policy initiatives or aims to create some structural changes. And the question is particularly regarding reducing environmental chemical exposures for for adolescent girls and young adults through any regulatory actions.
Yeah, that's a great question. In fact, we're not, one thing we aren't doing, as I alluded to earlier, we're not getting too far into the basic science or the biomedical aspects of women and cancer, but we will certainly mention the important initiatives that already exist and ask others to take up the cause and continue in that domain. I will draw your attention to the WHO's Cancer Agency, the International Agency for Research on Cancer, IARC, that has a monographs program that is completely tasked, that's what they do, is by looking in the most unbiased way as is possible to gather the evidence and make some adjudication about the hazard, meaning the likelihood that the evidence is, the strength of the evidence that chemical ABCD is actually carcinogenic, for example. And then the WHO can take that forward in some cases to estimate with others what is the actual risk associated with that hazard. And so that's for girls, and that's for men and women for that matter. But there is a lot that needs to happen to improve, this is my personal opinion now, to improve or to create and implement policies to protect people from chemicals that have not been tested. That's a big issue. And we don't know what we don't know, right? So thank you for raising that important issue. Yeah.
Thank you. I think another question is, and this really relates to maybe health systems overall, and what I often call like using a platform of trying to tackle more than one condition, and that gets at particularly HIV programming. And as you know, there's been a massive scale up of HIV prevention and treatment and so on in many countries around the world, particularly in the African continent. And, has there been attention to the opportunities that this offers by reaching large numbers of women, young women, both at risk for HIV, living with HIV, and trying to do some of these prevention interventions, utilizing, the HIV platform overall?
Oh, fantastic. I'm glad you brought that up. And I tend to want to give the dramatic, this is the reality in my talk. But what I sometimes don't do, and I didn't do enough today, is to say there's lots of opportunities. And there are already good examples of exactly what you say, of integrating programs that can also serve to strengthen the health system, such as having cervical cancer screening programs as part of a comprehensive healthcare, not just the facility, but a health intervention, particularly for women living with HIV. As some of you might not know who are listening to this, living with HIV is a very strong risk factor for cervical cancer. You're more than 5 times as likely to develop cervical cancer, and you're more likely to be in a population where you may not have access yet to high quality cervical cancer prevention. And so integrating these programs can be a great way to leverage, assets and improve health. PEPFAR, of course, has long had a program like this, which I know you're aware of, Wafa, and others might be too. The same could be said for breast cancer. So having women's cancers programming, education, and care as part of an HIV, or if you're talking about prevention of HIV, then there's another opportunity in a different healthcare setting that might be more oriented around non-communicable diseases, for example, that introduces HIV prevention and care.
Yes, and certainly you're right. And through PEPFAR funding, ICAP has been, and other partners have been, in the really working hard at integration of cancer, particularly cervical cancer screening for women living with HIV, and also just did a pilot very recently of breast exams and teaching providers and individuals how to do so. So I think there's a movement there, just the beginning of efforts in that space. Another question is the issue that I'm sure you're well aware of, which is the building the workforce capacity in terms of both diagnostic, but also in terms of the management, and particularly in terms of specialized clinicians, but also multidisciplinary teams and other types of providers, and also other types of expertise, like pathologists, for example, radiologists, and so on.
Yes, in fact, you can't do anything in cancer care without care. I mean, you can do a lot in prevention, but you can't do anything in cancer care without appropriate access to prompt diagnosis. And so a recent Lancet Commission on diagnostics, actually, it wasn't just about cancer, but addressed this. It's a huge gap, and it's a huge area that we need to do better to address through, I mean, there's many ways to come at this, and it's a bit off out of scope of our commission, but just to acknowledge, how can we better use the resources we have while we're also trying to engage in capacity building? That can be done also partly through twinning partnerships. There's the American Society of Clinical Pathology, led by Dr. Dan Milner, that many of you might know, who's just tirelessly helping to serve the needs to build quality pathology through telepathology, but also being there on the ground, teaching about existing technologies like immunohistochemistry, which is still the mainstay to a large degree. But there are also ways to, I don't know if people like the term leapfrog anymore, but anyway, to move ahead into the area of molecular pathology, which may sound ridiculous. I used to think, and I'm a cancer geneticist actually by training, I used to think, my goodness, why are we looking at molecular when there's still 2 patients per bed, as I used to see? I didn't include that slide in the main cancer hospital, anyway, a number of years ago in Hanoi, where I used to work. And in fact, they're right. So using that same machine, I don't have to use the brand name, that you all use so much for PCR of other conditions, including TB and then COVID. And, this, of course, is a way to test for cervical cancer. And now there's a newer device that you can use that can also help to detect and classify the type of breast cancer a person has, that can guide treatment. And that could be done with the same machine that's used for, I mean, this is tremendous, right? So having that knowledge and helping to leverage the assets you have is one way, but absolutely we need to broaden the health workforce, and also to encourage people to see non-MD providers and non-oncology providers as being capable of doing a lot of the, not all of the work, but a lot of the work. Even in Canada, we had the GPO program, the General Practitioner Oncology Program. It's been around for a long, long time. And here you have nurse practitioners in the US and other non-oncologists who can actually do a lot of the high quality cancer care. We just need to look at what we have and realize what we have before us.
Thank you. Then maybe one of our last questions here is, as you can imagine, our audience is very much interested in research as well. And one of the questions from a student is regarding, you presented on the intersection between gender and socioeconomic status and cancer burden. And the question is whether, how the commission and how you will dissect this information and shape some actionable actions to try to overcome the cancer gap for women.
Right. Well, that's pretty much what we're about. So it's hard to say in just a minute how we're doing that. One way we're doing this is by having brought together people with very different areas of expertise and perspectives. Only about half the commissioners are what I call cancer people, and the other half are people who have expertise in all these other areas of health and and non-health to put those kinds of minds together in a room, and as we have been doing through virtual rooms for 2 years, and to come up with a framework that can help inform some policy guidance. Some things as simple as, not so simple in reality, but simple to consider. Why aren't we capturing data on gender and gender identity as well as biological sex, right? Why aren't we capturing data on ethnicity? And I'm going to say the word race. I know that's it's a cultural, social construct, but self-described race and other elements, so we can actually see what's happening in the real world and help target our solutions effectively. That would be one of many things we may likely come up with as part of our recommendations. And then if those of you are interested in learning more, please do connect with me. We are going to need, it takes a village. We're coming up with the recommendations. It's not like we're expecting that we'll be able to carry them all out or do that ourselves. This is where all the partnerships come in. And people interested in looking at something we might come up with that's relevant also to your own work. Lots more research needs to be done. We're going to raise a lot of questions as well. Thank you.
That's great. And I do think that everyone does look forward to the findings from the commission. I may have missed it, but when do we expect the commission to complete its work, Ophira?
Yeah, sorry, it was on a slide and I didn't actually say it. We're aiming for spring of next year. So that sounds like it's a long way off, but it's not. So we need to, we're now preparing our manuscript to submit for peer review quite soon, because there's about a 6-month need for a document of that size with all the rounds of peer review. So spring of next year, there'll be a launch event, a main launch, and then there'll be regional launches, one of which, by the way, will be, of course, on the African continent. We're going to link up with the African Organization for Research and Training on Cancer, aortic. The incoming president is actually on our commission, and that will be in Dakar, Senegal in, I believe, November 2023. So that will be the African launch, and we'll have other launches over the year.
Oh, that's wonderful. And we might as well, we would love to have you come back and share with us the key findings from the commission. I think there's a lot of anticipation for the policy recommendations, the research recommendations, and I'm sure there'll be many other recommendations as well from this very important work.
Thank you so much.
So I want to end by thanking you and for giving us this wonderful presentation today and highlighting a very important issue and for many of our attendees today. And I want to also thank all of the individuals who attended our webinar and let you know that this is recorded and we will be posting it and archived on the website. So please feel free to share with others in your community. Thank you very much, Dr. Ginsberg, and thank you, Dr. Jacobson, for this webinar today.
Thank you so much.
Thank you.